Good morning, everybody. This is about venous disease and pregnancy. I go over a little bit of the physiology of pregnancy, things that change during pregnancy and how they can kind of mimic what we see with venous disease, and also about venous thromboembolic disease. So as vein disease specialists, we actually see pregnant women and understand just from our clinical encounters with them that there is a correlation between multiple pregnancies, progressive venous disease, hormonal and mechanical anatomical changes of pregnancy affect the venous system, causing a lot of the familiar symptoms. And unfortunately, a lot of women suffer from heavy, painful edematous legs, and they're not offered very much. Hemodynamics in pregnancy, something to remember is that as you see increasingly pregnant women as they advance through their gestation, you get more vasodilation in the system. It starts early, it peaks around mid-second, late second trimester, holds steady third trimester, and returns to baseline postpartum. But you get vasodilation, you get a decrease in peripheral venous resistance, so you get a larger container with a larger volume. These will show up in increased heart rates, increased cardiac output, decreases systemic venous resistance. Blood pressure should kind of hold steady. They may decrease a little bit in the healthier folks. But a lot of these changes, the increased heart rate, the increased respiratory rate, will confuse the presentation of somebody coming in for possible pulmonary embolism. So you keep in mind a lot of the normal changes that you see in pregnant women. When you look for venous disease and risk factors of venous disease in pregnant women, previous pregnancies increase risk. So does advanced maternal age. So as you increase past that first pregnancy, where maybe 15 to 20% of pregnant women will show up with varicose veins or venous disease, increasing age, increasing number of pregnancies, it seems the third is kind of the tipping point for most women where they'll really start to get more symptomatic disease. And of course, family history of venous disease is a risk factor for venous disease in these pregnant women. For women, as they progress in age, particularly over 35, 40, you'll see a markedly increased presentation of symptomatic venous disease. If it's only 20% in a first pregnancy, as women progress in age and over 3, to the 4 or 5, we've seen people with 9 and 10 pregnancies who have more varicose vein than leg at times. And it's really something that can be managed better than what we see for a lot of women. There was a little study from Brazil that looked at 352 women. They felt that venous disease was underrepresented in a lot of the literature, saying that there was only 15 or 20% of women with venous disease in later pregnancies. They looked at all of their patients, nice, healthy women, lightweight women for the most part, and felt that if you counted all SEEP categories, and they just did a clinical SEEP, they didn't do any duplex scans. If you counted women who had reticular veins and spider veins, there were actually about 72% of women who presented in pregnancy with venous disease. So more than what the literature had accounted for up to that point. If you look at the pathophysiology during pregnancy on what contributes to symptoms on presentation, there are 2 main mechanisms. There's the mechanical theory and the hormonal theory. The mechanical is more from the compression of the baby getting bigger, the uterus getting bigger, and more compression on the great vessels, the vena cava, the iliac vessels throughout pregnancy. And then the hormonal theory goes back to that more volume in a distended system. When you look at folks at the end of pregnancy, femoral venous pressures in supine position, it can be increased 3-fold. And you look at the system here when women are supine, which is something to keep in mind if you're going to do DVT rule-outs in advanced gestations. This system is lying right on the great vessels, compressing it against the vertebrae, and you can get near complete occlusion of the vena cava in a supine position, which is why we do tilt women off to the left side a little bit to relieve some of that pressure. And if you look at the MRI image, that's a pretty significant compression of those vessels back there. So supine hypotension syndrome, if you're doing DVTs on advanced pregnancies, try to be mindful, tilt them off to the side a little bit if you can, so you don't have a mom who feels lightheaded, dizzy, hot, sweaty, faint while you're doing a DVT evaluation. An interesting look at the hormonal component of this is this great little graph. This is from the American Journal of Obstetrics and Gynecology in 1943. They looked at antecubital pressures versus femoral pressures and found that even before the uterus gets significantly enlarged, to apply a lot of compression to the femoral and the iliac vessels, you get this marked increase just in the first trimester. The uterus is, at most the size of a grapefruit at this point, and you don't get significant compression very early on. So what they concluded, because it does increase as the uterus gets bigger as well, is that they feel that the hormonal mechanism is the primary change, and then the pressure or compression is the secondary change that causes all of these issues during pregnancy. So I thought this was interesting because it was so many years ago. When you look at another little study out of Brazil that was reported in Phlebology, this group looked at pregnant women who had no other comorbidities in their pregnancies to track venous disease, presentation of venous disease. And we're looking to see, are there changes that occur during pregnancy that are important and should be addressed during pregnancy? Should you do studies, on these women during pregnancy? Does it really matter what changes you get in duplex studies or APGs for treatment or use postpartum? So they only had 23 women because 2 of them gained a little weight and their BMI went up over 25, but they did duplex scans and APGs each trimester and postpartum. They found a couple little changes, but nothing significant. Again, a very small study, but the conclusion that they came to essentially is that there wasn't any reflux observed in the postpartum period. So doing a study for reflux during pregnancy doesn't seem to give you much information or do much for you for these women. There are some other little studies that have been done to look for the same thing. And essentially what everybody comes to the conclusion of is that gestational venous changes go back to their baseline, at least in the postpartum period. And so doing a study during pregnancy doesn't seem to give you much information. When we look at pregnant women who present with symptoms of venous disease during pregnancy, it works out better to talk to the patients about what's going on, what they're feeling, what changes they're experiencing, and reassure them that a lot of what they're feeling will subside a bit in the postpartum period, that it's common. Complications are rare. If they come back, they're assessed and they're treated, and always recommend that they come back for evaluation of any painful varicosity, symptomatic phlebitis, DVT symptoms, because they should know that they are at an increased risk for venous thromboembolic disease during pregnancy. So reassure them that they're not dying of something right now, but to be aware of what they should come back with should something present throughout the pregnancy. And then recommend they get a full evaluation in their postpartum period, 6 to 12 weeks after they deliver, so that they can have better legs for the next pregnancy, knowing that each subsequent pregnancy compounds what they're feeling with this pregnancy. So a full insufficiency scan really is not recommended during pregnancy. Wait until afterward. What you can offer them during pregnancy is just information on how best to care for themselves and their legs during pregnancy. Rest when they can, left lateral decubitus, elevate their legs, and then keeping in their best physical shape, which is always a conversation to have with pregnant women for many reasons, but watching their weight, just like our obese patients who are not pregnant. Weight management's important, how much you carry on your legs, how much you carry on your back, getting to be more uncomfortable physically during pregnancy because you get more deconditioned and out of shape makes everything kind of fall apart during pregnancy, but it's bad for your legs for long-term as well. Going into the discussion on compression stockings, if somebody doesn't have significant skin changes and a lot of swelling, you can start with a lightweight stocking, excuse me, and then increase that as presentation or as symptoms increase. And something that is very significant for pregnant women is that getting compression stockings on when you have a bigger belly, your flexibility is limited, or it's the middle of July, can be difficult because compression stockings are more difficult to get on as your flexibility decreases, just like our elderly folks and the folks with arthritis. So layering compression is actually a reasonable approach. If you start with a couple of lower grade compression stockings and layer those on, and you get relief, you get comfort, women can then strip off a layer here and there if they get warmer, if the weather is such that they just can't bear the thicker, heavier duty compression stockings. But I think talking about compression is important because that gives women something to do to make those legs a little bit more comfortable. And it doesn't feel like you're telling them, I'm sorry, you got to wait until you're done being pregnant. There's nothing we can offer you. For vulvar varicosities, for pelvic pressure, pelvic heaviness, there are some supports out there. They're not fantastic. The V supporter for vulvar varicosities is really limited. We used to have women pack like sanitary napkins with cool packs in there just to alleviate some of the discomfort from vulvar varicosities. These prenatal cradles and belly bands will kind of pull that uterus and the baby in and upward a little bit and can alleviate some of that pelvic pressure. So if you at least know that there is something out there that can help and you can provide them with the information to go and look and talk with their obstetrician about using these, this is something that is a little bit more beneficial than nothing, but delivering the baby is the ultimate for that. And certainly we don't treat pregnant women. So on to actual DVTs and pulmonary embolisms in pregnancy. Pregnant women have an increased risk for thromboembolic disease. So the likelihood of seeing a woman in our practice with a DVT during pregnancy does exist. We're quite likely to see pregnant women with SVTs, DVTs, and postpartum patients with DVTs. The events are about 50-50 between during pregnancy and postpartum, but their risk per day for a thromboembolic event is greatest in the weeks immediately following delivery. Something to consider as well is their mode of delivery, whether they were a surgical delivery or a vaginal delivery. And with women being discharged earlier and earlier over the past several years, you're very likely to see women who are almost immediate postpartum, the week or two after, who still have a lot of the residual from their pregnancy and their delivery, whether they had an infection or whether they had a hemorrhage or any kind of complication during their pregnancy. This impacts their risk for thromboembolic problems as well. When you look at the events, most of them are DVTs. Fewer of them are pulmonary embolisms, but the mortality is quite high. It's a significant cause of maternal mortality. The changes that are associated or increase the risk during pregnancy are, of course, the hypercoagulability that you see during pregnancy. You've got stasis, you've got more compression of these vessels as the baby gets bigger. So you get more obstruction of outflow, you get compression, like that May Turner kind of anatomy back there. Decreased mobility plays into this as well. Obesity is a big part of life lately. We have more obese pregnant patients as well, but general decreased mobility as women get bigger and heavier and they tend to move less. You get the whole varicose triad of the stasis and the endothelial injury and the hypercoagulability going on in pregnancy as well. When you look at the hypercoagulable state and the changes during pregnancy, fibrinogen and factor 7, factor 8 are all increased. You have an increased resistance to protein C, even though it does not change in its level. But all told, remember that there is an increased risk of clot because of the factor changes during pregnancy. That it's important because the placenta has to grow into the myometrium. And so as those villi are breaking into the vessels in the myometrium so that you can establish that maternal fetal placental circulation, you need to be able to break into blood vessels and establish a connection without over clotting, but you don't want the mom to bleed to death. So this is in an attempt to balance that placenta being able to implant into a uterus properly. So we have to watch for women who have bleeding issues during pregnancy, as well as clotting during pregnancy. Risk factors, when you look for DVT, risk factors in pregnancy are all the same as non-pregnant. Being older, being bigger, smokers, family history is always important, personal history is important. And then any complication of pregnancy can increase your risk for clotting. So dehydration, folks who have hyperemesis early in pregnancy or any other medical problem during pregnancy, if they have CHF, if they get preeclampsia, if they have any surgeries during pregnancy, C-section for delivery, any traumas, any broken legs, or, I've had patients who've had breast cancer during pregnancy. Severe varicose veins, that's another conversation to have if they do come to visit you. Like I said, explain what those are, what risk they play, why compression is important, and then why it is indeed important for them to come see you if they get a phlebitis, because we do need to manage that. With pregnancy, D-dimer levels are generally increased as pregnancy progresses. So when you look at what type of workup to pursue for folks who could potentially have a DVT, the risk is equal across all trimesters for the most part. These clots do tend to involve the iliac and the iliofemoral veins, and they do tend to embolize. It is very important to know that women in pregnancy don't necessarily come in with a Holman's, calf pain. They may have more thigh and buttock pain, significant asymmetrical swelling more on the left side than the right side. Remember that ACOG does not recommend looking at D-dimers for working up these folks for a DVT, because it hasn't really been found to be the best test due to the physiologic increase that you see during pregnancy. However, depending on where you work, what your resources are, if you were to draw a D-dimer and it's incredibly low and you have a low suspicion for DVT, a lot of little clinical studies show that it's got a pretty good negative predictive value if it's really low and your suspicion is really low. In patients who you are concerned for a DVT, if you don't find one on a duplex of their legs, you really have to try to assess more proximally. If you have the ability to do CT scanning to look up higher to see if this could be an iliofemoral, an iliac pelvic vein clot, you will do them a service to find it and know about it and remember that. So postpartum, you can address the changes that occur with pelvic DVTs. To treat somebody with anticoagulant, if you don't have the ability to do a CT scan, is a conversation with a mom as well. And you're not wrong to talk about doing some low molecular weight heparin until you can get them better assessed for a more proximal DVT. So this is simple workup. This is the obvious makes sense one. Do you suspect a DVT? Do an ultrasound. If it's positive, treat. If it's not, consider doing a CT scan, looking up higher. You could do routine surveillance as well. If somebody really doesn't present with overwhelming signs, symptoms of a DVT, but you haven't felt comfortable that you can completely rule it out, you could watch them every 3 to 7 days with serial ultrasound as well. For PE, there are no specific clinical signs or symptoms. Common presentation during pregnancy is dyspnea, a little chest pain, just from that increased compression of the uterus on the deep vessels, but also the excursion of the diaphragm is less as the pregnancy progresses. And so women get a little dyspneic or a little just breathless at times. Increased heart rate, increased respiratory rate, like I said, is something that is part of pregnancy. So when you're looking at a woman and you're considering whether or not she has a PE, you really have to have a high index of suspicion, because even though you don't see many of them during pregnancy, personally, it's 20% of maternal deaths in the United States. So there are actually a significant number of women who die from PE during pregnancy. So still important to keep that in mind as you look at these women. Knowing that the Wells score and the PERC criteria have never been validated in pregnancy is important. So remember that D-dimer is not an optimal test, and that these scores are not optimal tests, because there's new news that's come up that kind of contradicts this just a little bit. When you're looking for a way to evaluate for pulmonary embolism, the idea that more than 95% of PEs come from a DVT, it's a good thought that you look for a DVT in pregnant women, particularly if they have leg symptoms, obviously. But if you've got kind of soft symptoms and you do a DVT scan and you have a positive scan, well, you're going to treat them. So treat them with anticoagulant because you found a DVT, and you can call it a clinical diagnosis of a pulmonary embolism, and you don't necessarily need to do any additional study to prove that there's a PE if you're going to treat them with anticoagulant anyway. In 2013, there was a study on 221 pregnant women, and they did ultrasounds on women suspected of DVT. If it was negative, they followed them every 2 to 3 days for 3 months to see if they were going to miss anybody who could potentially have a DVT, go on to have an embolism. And what they found is that if they did serial ultrasounds, they didn't find that they missed anybody with a pulmonary embolism. So the sensitivity of their duplex scans was about 94%. So they feel, their conclusion was more that if you don't have an overwhelmingly sick person presenting, you can follow them with serial ultrasound and be comfortable that you're not going to miss a significant problem in these women. If you're uncertain, or you're in a place where you do have the option to do VQ scans or CTs, the question is, what do you do? When do you do? Both are relatively low radiation exposure to the mom and the fetus. Fetal exposure from VQ is lower. Maternal doses with the CT, especially in breast tissue, are slightly higher, but overall, the International Commission of Radiologic Protection feels that both studies expose the fetus to a negligible amount of radiation, especially when you consider mortality risk of pulmonary embolism. So in those folks that you really are worried they do have a pulmonary embolism, you haven't found a DVT, and you have to convince yourself, the mom, their perinatologist, whether or not they have something that merits treatment, you have to decide which test you're going to choose. It also depends on your radiologist's level of comfort with the tests in pregnant women. The American Thoracic Society and Society of Thoracic Radiology throws a chest x-ray in their algorithm. So you look for DVT when there are leg symptoms present, treat them if they're positive, makes sense. Then if you do a chest x-ray, depending on whether it's normal or abnormal, they choose one test over the other. They found that if a chest x-ray is abnormal, the CTPA gives you a better correlation with pulmonary embolism than does the VQ. But if your chest x-ray is normal, a VQ seems to give you more information. When you do a chest x-ray in any patient who has a suspicion of a PE, you get a normal result in more than 50% of patients with a proven pulmonary embolism. So there's always been the question, do you do a chest x-ray at all? But there are alternative diagnoses that you can get from a chest x-ray. So maybe you don't have a pulmonary embolism, but there's a pneumothorax, there's pneumonia. You can have a mass that can cause symptoms that are not a pulmonary embolism. Patients have sarcoid. Patients do show up with cancers or with other problems during pregnant COVID lately. So a chest x-ray is not a high-risk test, but can give you information that allows you then to choose whether to go with a CT or a VQ scan. So the thought is that women with a normal chest x-ray are more likely to achieve a diagnosis when they're studied by VQ scan compared to the CT, and the abnormal chest x-ray is better with CT scan. So a way to triage patients, perhaps. Something that's newer is the YEARS algorithm for pulmonary embolism. And this test was actually externally validated. There were 3,300 patients. And in this study, pregnancy was not a contraindication. So they had some pregnant women that went through this algorithm, and they were hemodynamically stable. They were more than age 18. And these were inpatients and outpatients, pregnant and not. They used what? The three most predictive criteria of the Wells score. So again, we were revisiting, the Wells criteria, and they choose these clinical signs of DVT, the hemoptysis, and whether PE is the most likely diagnosis given the patient's presentation. And they use the D dimer as well. So there we go back to the D dimer. If there were no years criteria present and the D dimer was less than 1,000, they ruled out PE. Same if you had one or more of the years criteria and a D dimer was less than 500. These patients were considered as not having a PE, and they were followed for 3 months post-presentation. So what they found is they did a lot fewer CTPAs in patients who they ruled out by their criteria. They followed them, and they did not find that they missed a significant number of patients who were who had a pulmonary embolism or who had an increased risk for pulmonary embolism. What they did find that they caution is patients who have a D dimer less than 1,000, but had an age-adjusted D dimer cutoff that was a little elevated, have to be watched a little bit more closely, and you may consider actually doing a CTPA on those folks because they had a little gray area in there where some of their folks had an age-adjusted D dimer that was a little higher. Also, they couldn't extrapolate this to cancer patients, so you shouldn't use this on cancer patients. But these same people took this study and they extended it. And this is a prospective study on pregnant patients, which you hardly ever find. So the Artemis study is a study that is prospectively done. They had 498 pregnant patients who they evaluated with the years criteria and drew their D dimers. So this has been validated in pregnancy. So you can see up here, this study, watching these women through the course of their presentation, they found that they ran them through the algorithm, and they looked for DVT, pulled those patients out, and if they had a positive DVT study, they called them clinically a pulmonary embolism because that's what they were presenting with the signs and symptoms of. They used the no years criteria and the less than 1,000 and the 1 to 3 years criteria, and the D dimer is less than 500 as negative. And they did CTs on the folks in the other categories. So they had 4 DVTs. So they had 4 pulmonary emboli that they treated for there. In the 2 groups where they did the CTPAs, those with no years criteria and had a D dimer of greater or equal to 1,000, they had 1 pulmonary embolism. The women who had 1 to 3 years criteria and a D dimer of greater than 500, they had 15 pulmonary embolisms. So they had 20 PEs altogether in their 500 plus women. On follow-up, following these women up for the 3 months after their presentation, they saw them as needed if somebody's symptoms changed, if they had new symptoms, and they were very good about follow-up, and they got a good solid 3 months of follow-up in these women. They had no pulmonary emboli that they missed during follow-up. They had 1 symptomatic popliteal DVT at day number 90 in 1 patient, and found that and treated that. So what they felt was that no patient receiving a diagnosis of PE during follow-up, this was a safe way to follow patients with presumed pulmonary embolism or who were presenting with pulmonary embolism symptoms. The specificity of the test was best in the first trimester compared to the third, and that's just because of that physiologic change in D dimer during pregnancy. But with this study, with these findings, ACOG is actually going to consider this in the future guidelines with regard to evaluating pregnant women with suspected PEs in pregnancy. So at this point right now, all of you know a lot more than the OBGYNs out there with regards to how to look at and possibly evaluate and follow these patients who are presenting with potential pulmonary embolism. Treating venous thromboembolic disease in pregnancy, it's low molecular weight heparin for the most part. We don't see a lot of women on Coumadin early in pregnancy, but something to remember is that there are some patients who are on Coumadin for valvular heart disease. And if possible, they really should be off of their Coumadin in the first trimester, just because there is a teratogenicity from Coumadin exposure for fetuses in the first trimester. You can use unfractionated heparin as well as low molecular weight heparin. Neither one of them cross the placenta, but low molecular weight heparin is easier to use. It has a more predictable therapeutic range, fewer bleeding episodes. The unfractionated heparin takes a lot more to titrate for the increased plasma volume, increasing weight in pregnancy. It has a shorter half-life, which is why there used to be recommendation. And the answer on the test is still that you convert from low molecular weight heparin to unfractionated heparin before delivery, because it does have a lower half-life and it supposedly is a better way to manage patients with VTE immediately before their delivery. For the most part, folks have gotten really comfortable with just discontinuing low molecular weight heparin 24 hours before delivery, rather than going through the complexity of managing a changeover to unfractionated heparin. When you look at the ease with which you can use low molecular weight heparin versus unfractionated heparin, this is why most of us have stuck with low molecular weight heparin. The prophylactic dose of low molecular weight heparin is 40 milligrams sub-Q once a day. When you look at the prophylactic doses of unfractionated heparin, you've got different doses based on trimester, which also has to be titrated to a PTT body weight. The 40 milligram enoxaparin or Lovenox is a pre-filled syringe. Some of these heparins still have to be pulled up into a syringe. You have to have the right number of units in a syringe. It's a little more complicated for folks who are not necessarily medical types. And the titration and following PTTs just gets to be aggravating after a while. So low molecular weight heparin in a population that's really not happy about injecting themselves isn't easier, and it does promote more compliance with these injections. When you look at the adjusted dose, low molecular weight heparin is 1 milligram per kilogram every 12 hours. You can follow anti-10A levels 4 hours after an injection to look for their range being between 0.6 and 1 unit per milliliter. When our perinatologists do this, they do this every couple of weeks at first, and then they'll fade off and very rarely check these because they're pretty consistent throughout pregnancy, as opposed to the PTTs and monitoring the unfractionated heparin and constantly having to up and down doses a little bit. For pulmonary embolism, low molecular weight heparin is generally the way to go. For Coumadin use during pregnancy, we really recommend not using that if possible. If cardiologists really want their patients on this, if they have valve disease, because there can be catastrophic valve thrombosis, even with heparin, getting them off the Coumadin first trimester or even before they're actually pregnant, if they're planning for pregnancy, is the best thing to do. And then if they have to go back on their Coumadin, going back after the first trimester, and then again, going back to a low molecular weight heparin closer to the time of delivery. So there's a little bit of shuffle back and forth. For anybody who needs Coumadin during pregnancy, it's possible. And then being back on their Coumadin postpartum is not a problem. Postpartum Coumadin use is compatible with breastfeeding, so we don't have to worry about that end of things. The DOACs, NOACs really haven't been tested in pregnant women. There's really no safety data, nothing new that I could find lately on DOACs and NOACs. Fondaparinux has been used a little bit during pregnancy where there's heparin allergy or significant thrombocytopenia, and just on clinical use and watching these folks, there hasn't been anything untoward discovered at this point. It does cross the placenta a little bit, but it doesn't seem to cause any coagulation or bleeding issues in the babies that were born to moms who use this. For thrombolysis, catheter directed as opposed to systemic. And again, it's in the limb and life-threatening situations. There hasn't been a formal study examining the effects of thrombolytics in human pregnancy, but in patients who present, again, this is where you have to look at the mom as a patient and not just as the carrier of a baby. If mom's life or limb is threatened, you really have to preserve her life and hope that baby's going to come along. But if there's no mom, there's no baby, and there's no future either. So you look at this person, as a person first. And if there is something threatening mom's life, threatening her limb, then to go forward with a catheter direct thrombolysis would be the right decision. Again, even, if she is pregnant, because, and you can have the conversation with the mom and the family, but for the most part, it's the right decision if it's a seriously threatening situation. For cable filters, it's not a perfect use in pregnancy. If you have a really high risk recurrent VT, somebody who, despite adequate anticoagulation, has clotted again, or a very large iliofemoral clot, pelvic clot, somebody who's got a huge threatening clot immediately before delivery, you don't think you can get them properly anticoagulated, or your vascular surgeon just believes that the filter is the best thing to put in for this patient based on risks and presentations, a filter can be placed. The risk of filter migration and perforation of the IVC is higher during pregnancy. Think about all that obstruction. You've got a more dilated system. You've got more laxity in the vascular system, more volume, that's hopefully flooding through there at times. So it's a different system that you're putting a filter in. And then certainly it should be removed postpartum. So these are not common, but it's still an option if you have a patient in that situation. When you look at whether or not to prophylax patients for VTE in pregnancy, you have to go through their whole history, just like you would with anybody else. Their past history of clot, their family history of clot, OB complications, their immobility, any known thrombophilias, and choose wisely on who to prophylax and who not to. Any clot during pregnancy needs anticoagulation for the duration of the pregnancy and at least 6 weeks postpartum. So it's a long-term commitment if you get a clot anytime in pregnancy. For prophylaxis, anybody who's had a history of a single unprovoked clot should be prophylaxed. Anybody with a history of a clot with hormone use or previous pregnancy should be prophylaxed. A low-risk thrombophilia with a family history or a personal history of a clot gets prophylaxed. A high-risk thrombophilia with no history of a clot gets prophylaxed. So those folks who could potentially get a clot but aren't very high risk use the prophylactic doses. Your higher risk thrombophilias and a personal history of a clot, you start them on anticoagulant as soon as they're pregnant. A history of 2 or more clots, they get adjusted dose, low molecular weight heparin. With antiphospholipid antibody syndrome, if they carry that diagnosis, they should also take a low dose aspirin in addition to the anticoagulant. High risk thrombophilias for the test, antithrombin deficiency or antiphospholipid antibody syndrome, factor V Leiden or prothrombin homozygous or compound heterozygosity are higher risk thrombophilias. Lower risk are the heterozygous states, protein C, protein S deficiency. This is all theoretical when we're talking about treatment of DVT and pulmonary embolism or during pregnancy. These are all the things you need to know for treating. Ultimately, pregnant women, when they have a significant clot, many would argue for any kind of clot, they really need to be hospitalized because you need to establish the viability of the pregnancy. Are they truly pregnant? Where are they pregnant? What, is there a heart rate? If you start somebody on Lovenox as an outpatient and 3 days later they go to the hospital and their baby doesn't have a heart rate, you're going to be part of the look what you've done to my pregnancy kind of problem. So you always have to know what the status of the pregnancy is before you add a medication to a pregnancy. So they need to be in, they need to have monitoring. If they are significantly pregnant, they have to have an ultrasound to establish where and the viability of the pregnancy. Is there any other complication associated with the pregnancy, like a subchorionic bleed or a previa? And then getting your perinatologist involved with the management of this pregnancy to follow anti-10A levels or to follow ultrasounds, follow fetal growth, follow any bleeding issues is important. So this is a multidisciplinary approach that is best started in the hospital for patients. If you find a clot or if you have a suspicion of a PE on a patient, sending them to the hospital, letting their obstetrician know is typically, our part in this. If you work in a clinic or a hospital-based practice and you're seeing these patients, then you know a lot of what should be done, but you're always going to work with the perinatologist on getting it done. When you see someone who's pregnant with an SVT, if you've ruled out DVT, treatment of an SVT, they're the same parameters as non-pregnant patients for prophylaxis of this. The 5 centimeters or greater in length, the proximity to the confluence of the deep system, and the treatment is 40 milligrams of Lovenox sub-Q daily. Again, you recommend this, you tell them that this is what they should do, but you must confer with their OBGYN because you do not know if any of these women are currently walking around with a subchorionic bleed, an undiagnosed ectopic, or whether they could have a retroplacental bleed or a previa. And if you bring out bleeding on a pregnant woman and something happens to their pregnancy, you will forever be involved in whatever course of pregnancy thereafter. So keep this in mind, know what the recommendations are, but always work with your OBGYN to make sure that this is a safe patient to anticoagulate. Then I'd just like to throw this in there. If you have a patient or you see somebody who's had a significant clot during pregnancy, a femoral, iliofemoral, remember that they are at risk for that May-Turner anatomy and that you should then see them postpartum to not only look at their legs, but to look up at their pelvis, look up at their iliac vein, at least a pelvic ultrasound, if not a venogram and IVUS, so that you know what their status is going into the next pregnancy, whether or not they want a venoplasty or a stent placed. This then puts them at risk for subsequent DVT, and you'll know more about what to expect, and they'll better be able to be prophylaxed and or treated in a subsequent pregnancy. We also have that nice study from Center for Vascular Medicine that if somebody is significantly symptomatic from compression in their iliac system, that they do well during pregnancy with a stent in place. So planning for future pregnancy, this is important information to have going forward. And I think it makes us smarter to know what's going on anatomically before they get pregnant again. And that's all I got.
Thanks, Theresa. That was really comprehensive. I think I thought I knew a lot about pregnancy and emergencies and DVTs, but I think you proved me wrong completely. So thank you very much for that. Any questions, anybody?
That was really great. Thank you, Theresa. When do you decide to do an insufficiency study after pregnancy? What's your time horizon and when do you initiate treatment? When do you think normalization occurs?
So I tell everybody to wait until 12 weeks postpartum. They've got so much going on with their recovery from delivery that life seems to settle down a little bit more, and they seem to be ready to approach another problem. You know, if you're working out childcare and breastfeeding and recovery from a C-section, you need to have somebody whose head can be wrapped around potentially having venous disease and going through treatment for that. We also have folks who have their breastfeeding routines established usually by 12 to 14 weeks. And if you're going to treat someone, doing radiofrequency or laser is fine, but you want to avoid foam during breastfeeding unless they're going to pump and dump. And we don't really know how much foam would be a problem during breastfeeding. I doubt that it really goes across breast milk in any kind of significant quantities, but the potential to expose anybody's kid to anything, I have them pump and dump for 24 hours if they want to get all of their treatment done with Varithena or ultrasound guided as well. So I give it time for them to sort of recover physically and mentally from pregnancy. All right.
I think, Phil, from a logistics standpoint, when do we see these patients? So, I get this question all the time from some of the doctors and say, hey, I have a patient that comes in and they're pregnant, and the call center will set them up, whether right or wrong, for a PVN. They're told not to do that, but we have so many different doctors, and everybody has a different preference on this. But I'll tell you that my personal opinion is the right way to do this is that a pregnant patient should be seen if they're having any leg pain, and they should be a DVT rule out. If the DVT is negative, then I just tell them, hey, look, right now, compression stockings, please give them my phone number. This is your way to kind of build a relationship with the patient, so that way they come back to see you, because invariably they're going to need treatment at some point later on down the road. Now, if it's positive or if it's super extensive and I get really involved and I got to, talk a lot about the things that Theresa's talked about today, then I convert those to a PVN. But, we have some doctors in our group that just are animate about making every patient, even if they're pregnant, PVNs. And I think that is not the right way to handle these, because just like what Theresa's mentioned so far, physiologically, there's just so many changes that a woman goes through during pregnancy that their insufficiency study is going to be abnormal, right? If you increase their volume and then you put a big tumor in the belly and it's compressing down on everything, there's going to be insufficiency there, and that's just expected. Okay. So ultimately, they should be seen for a DVT rule out, and then they should come back and see us in 12 weeks or so after their body normalizes, and if they're still having symptoms. That's probably the right way to handle that.
Yep.
No, I get that. I agree. I had a very thin young woman come into the office a week after her C-section, and she hid that fact from us. And she had some insufficiency. I was a little surprised based on her physical exam, just looking at her body habitus. And I was talking to her about, possible treatment, completely unaware that she had a baby a week ago by C-section. And I did a real exam like I've always done. And I'm like, well, what's this? Why do you have a scar? Oh, I had a C-section a week. I'm like, we're not doing anything for 3 or 4 months. We're going to see if you normalize. And she did. I was just curious what your time horizon was.
Yeah.
I mean, how these people can be.
They're still hypercoagulable at that point too, right? The
Right.
coagulation system doesn't really recover until 3 months later. So, why increase your risk for a blood clot doing a radio frequency 6 weeks after delivery?
But people get these ideas in their head about what they think they want, even if it's not beneficial to them. And so you got to stand strong, I think.
All right.
Thanks, Theresa. Awesome talk as
Right.
always. I appreciate it. Have a good weekend, everybody.
Yep. Thanks, guys.
Thank you. That was great.
Thanks, Laura. My cheerleader.
Hey, I gotta ask you though. What are your thoughts on aspirin when they're nursing? I was gonna ask, but it's kind of controversial. So
Aspirin with nursing, did you say?
yeah, if they're breastfeeding, yeah.
It's not a low dose aspirin is not a problem, because we've used them in patients with antiphospholipid antibodies, and there's really nothing that's come across that said there's a sincere risk of any kind of coagulation problem in babies. They don't seem to bruise more or have any other issues. As far as when I've talked to pediatricians, they don't seem to be opposed to it if it's necessary for mom.
Okay, well, that's pretty cool. Yeah, some OBs are like, no aspirin. And I'm like, well, this person's had phlebitis, they're not out of the woods here. And
Yeah.
they take them off the Lovenox after they deliver, and then they're on nothing. And I'm like, well, we got to do something better than that.
No, absolutely. And I think, if you show the OBs, the information on SVT and why you treat and the length of time you should treat, I'm surprised that there would be much pushback on that, because the last thing I would want is somebody to have a DVT or an embolism because I undertreated something that should be treated. But
yeah. Well, I think they'd rather keep the patient on Lovenox for 6 weeks postpartum than they would even transition them to aspirin. And there's just this anti-aspirin kind of sentiment. So I just wondered what your thoughts were.
Yeah, I mean, there was the thought, that kids who had viral diseases, right, when they were young, shouldn't be on aspirin because of Rye syndrome.
Right.
But I don't think you can even trace the percentage of 81 milligram aspirin that goes through breast milk. I think that's kind of
Well,
overkill.
and I think the Rye syndrome thing with aspirin was really falsify anyway, because that's when I was growing up, and that was kind
Yeah.
of how we all grew up, and I don't think that's even stood the test of time either.
Yep,
So
great.
it's good to see you. Great presentation.
Okay, have a good day.
Thanks,
Good
you
weekend.
too.